This is something to talk about from the Bainbridge Island Senior Community Center. It's sponsored by Fieldstone Communities of Bainbridge Island. Fieldstone offers compassionate care on Rolling Bay. To learn more about their apartments and get a tour, or to find out about day stay or respite programs, call them at 360-689-4314. Also, I'd like to acknowledge that the Senior Community Center is on the ancestral homeland of the Coast Salish, specifically the Suquamish tribe, the people of the clear salt water. We honor them and are grateful for their hospitality. Today, we're going to, thank you very much, Dr. David Cowan, return to the subject of COVID. Dr. Cowan is the co-leader of the Bainbridge Prepares Medical Reserve Corps and practices medicine here on Bainbridge Island. And boy, it's been a while, but the disease, the virus keeps showing up. In fact, we have had to notify people a couple of times in the last couple of weeks of potential exposures during activities here at the Senior Center. Thank goodness everybody is doing their best to be vaccinated. We encourage people to wear masks, but the COVID virus keeps mutating and finding ways to infect us. Thank you for checking in again, Dr. Cowan.
Yeah, my pleasure. And I'm sorry that we have to do it, but I think it is just the way it's going to be going forward. And fortunately, we're not really seeing the spike in deaths that we saw with previous waves. So I think that is a good sign, and a sign that the vaccine and our immune systems help.
Right. We're moving toward something that might be more endemic than epidemic, but we're not there yet.
Yeah, I mean, yes, we're somewhere in between. I mean, I don't think we've done this in a while, so it's hard to say exactly, but we do have a lot more options, in terms of treatment, and of course a much higher level of at least partial immunity in the community. And those two things, I think, seem to be making a big difference.
So you mentioned treatments. Paxlovid has been much in the news. If you can talk a little bit about what the purpose of that medication is relative to COVID. And we've had a couple of very prominent cases of rebounds, people who have taken Paxlovid and then almost immediately started to test positive for the virus again. I can think of Dr. Fauci and President Biden as a couple of examples.
Yeah, and I think that does suggest that this so-called rebound is more common than was generally acknowledged at the beginning. We're definitely seeing a lot of it amongst people who are actually checking. If you're not really checking for viral shedding with sequential testing after Paxlovid, you might not be aware of it, because those people generally don't have symptoms. But Paxlovid is a combination antiviral drug. It actually has two drugs in the Paxlovid pill that you take twice daily, and at least against earlier strains was phenomenally effective, about 88% effective in preventing hospitalization. It may be somewhat less effective against the BA.5 and BA.4 strains of Omicron. I don't think that's really been super well studied. It's a little bit hard to study, but it's still, quite effective. The good news, I would say, about the rebound is that some recent trials suggest that the rebound is not due to the virus becoming resistant to Paxlovid. That when you test the virus, if you isolate virus from people like President Biden, and then put it in a test tube with Paxlovid, the Paxlovid still works against the virus that's being produced after the so-called rebound. So that's not the problem. what it suggests that for one reason or another, there was just kind of an inadequate drug levels. I can't imagine with Dr. Fauci or President Biden that they weren't taking it as directed or wasn't being administered as directed. I mean, in the real world, I have patients who feel better and they stop after 3 days. And so that could explain some of it. But I'm pretty certain that Dr. Fauci and President Biden took it according to label instructions for the entire 5 days. And we still see the rebound. So, it may have to do with differences in drug metabolism. And that, would get into an area that, is beyond my, understanding really of the exact metabolism of the drug. Although the metabolism of Paxlovid is an important subject because it does affect, it's metabolized in the liver, and it does affect the activity of certain very common liver enzymes, not in a way that's harmful in any kind of permanent way, but it turns out that many, many, many drugs are metabolized in the liver. And so the main problem with Paxlovid is that it affects the metabolism of many commonly used medications. And especially if you think about the kind of target population, which is generally really, at this point, people over 65 who maybe have some other additional risk factor. I guess it depends, I would say, if they're over 65, kind of on their general health. If they're kind of a frail elderly person, then that might just be enough to say, yeah, we should probably use this medication. But certainly if they have any of the other major risk factors, including obesity or even overweight, which covers, unfortunately, a fair number of people, and they're over 65, then they probably should be getting an antiviral drug. But if you think about people over 65, a lot of them take blood thinners for one reason or another. A lot of them take statin drugs, cholesterol-lowering drugs. And for some of them, we can just kind of hold the statin drug for 10 days while they're on the Paxlovid. Blood thinners, that's generally not an option to hold it. So they just can't take Paxlovid. And I would say that affects, I should also mention renal function. They have to have normal renal function. And many people over 65 do not have normal renal function for one reason or another. So the dose either needs to be adjusted according to renal function, or they just can't take it if the renal function is below a certain threshold. So it really eliminates quite a few people who you would like to use Paxlovid in. I think it leads to two issues. One is, I think, a little bit of a lack of understanding of the complexities of using this drug. So I think people kind of think that it should just be available, with a phone call, or maybe just going to the pharmacy and just self-prescribing it. And obviously, given what I've just discussed, that's not a good idea, because these adverse effects can be lethal, and it would be counterproductive to kill people with Paxlovid.
Yeah, absolutely.
For trying to prevent hospitalizations and deaths, that's clearly counterproductive. So somebody who has a, I would say, in-depth understanding of the, pharmacokinetics and pharmacology of the drug needs to review the chart, and they also need to have access to the relevant information, not only the drug list, but the patient's renal function, which might eliminate pharmacists, actually, because I think they're allowed to prescribe it, but I just don't see how they have access to the patient's renal function labs in any kind of easy way. So that has created some issues. A lot of patients frustrated that they can't get the drug very quickly, although there is a 5-day window to prescribe it.
So could you talk a little bit about that 5-day window? Is that from symptoms first appearing?
Yes, that's from symptoms first appearing. or the positive test if they're relatively asymptomatic, or if that's kind of how they found out first. Whichever occurred first, I would say, is when the 5-day clock starts. And another thing I would say about Paxlovid and really all of the drugs that we're using to treat COVID at the moment is that the US government has purchased all of the doses, all of the courses. So I'd also have patients coming in or calling and saying, well, look, I'm traveling to Portugal and I'd really like to take a course of Paxlovid with me. And while that might be a good idea, I don't really know about the availability of Paxlovid in Portugal. Since the US government owns all of the doses, they get to decide how those doses are going to be dispensed, and travel to Portugal is not one of the current criteria for prescribing. So for patients who are traveling, I would say, they're going to have to kind of, try to obtain antiviral drugs locally if they end up needing them. I would say, fortunately, most patients who've been getting Omicron and who already have some immunity, really, my patients really haven't been getting that sick. And in fact, in some cases, unless they clearly are really high risk, like they're immunosuppressed or, as I mentioned, frail, I often recommend that they consider just obtaining the prescription, but not filling the prescription, and just seeing how they do over a couple of days. Because the Paxlovid does have some side effects. It can cause nausea, it can cause loose stools. It definitely causes a very bad taste in the mouth. And then, of course, the rebound that you've already referred to. And all of those, can be kind of inconvenient. The rebound in particular, if people are shedding virus again, that means they have to continue to isolate. And, for a lot of people, they just kind of want to be done with their COVID. So so I think there are reasons not, for maybe not everyone who's eligible to take it, but it is imperfect, I would say, in the sense that we still don't really understand the factors that predict who's going to get the sickest from COVID.
And
some of them are obvious, but
is Paxlovid probably the most common now treatment if you're going to try to lessen the risk of hospitalization, or do you have any other choices as a doctor?
Well, there are other choices. Probably the next best choice is somewhat unpronounceable monoclonal antibody called bamlanivimab, but sometimes referred to as BAM for obvious reasons. But that's IV only. And so just from a logistical standpoint, it has been challenging. It takes 4 to 5 hours per patient to start the IV, administer it, observe the patient after the administration for the required period of time. That requires personnel to do all of that. And in the current sort of healthcare staffing crisis that exists, that has been quite challenging. So we have not attempted to do that at our clinic, just because of the demands on personnel and time. I'm told that Kitsap General Surgery continues to offer bamlanivimab, which is a really nice service. I think they've sort of pivoted their practice a bit to become kind of a COVID IV infusion center, and they've just kind of stuck with that. So that's a great option. We also can have a couple slots a day, 2 actually, one at 6 a.m. and one at 8 a.m. at our Seattle emergency room. But obviously that's 2 slots for the entire population that's being served by Virginia Mason. So, all of Seattle, all of King County, Kitsap, Mason, Jefferson, that's not really a lot of accessibility to bamlanivimab. So from a practical standpoint, that's been challenging. And then there's a third option that I have prescribed, but with some misgivings, called molnupiravir. And molnupiravir is a somewhat unique antiviral agent in that it is metabolized into an analog for an amino acid, a nucleic acid that then gets sucked up as the virus is copying itself and takes the place of a normal nucleic acid in the sequence. And the clever thing about it is that it is similar enough to the cytosine and I think it's uridine are the two base pairs that it can substitute for. It's similar enough that the virus and all viruses have a proofreading system. So before they kind of turn themselves loose, the proofread goes through and makes sure that the sequence is correct. And so it's similar enough that it evades the proofreading step, and then the virus releases the copies into the environment, but they code for crazy things that it's not viable virus. So that's very clever. There are a couple potential theoretical problems with that. One is you could actually induce viral mutation inadvertently and create a deadlier virus or something like that. I think that's somewhat theoretical. There's certainly no evidence that that's been happening. More concerning to me is the fact that it looks like the nucleic acid analogs that molnupiravir creates may possibly be taken up during DNA replication. Now remember, the DNA is coming from you, the RNA is coming from the virus. So if it's exclusively affecting RNA, then it's staying in the viral world. If it's possible that it could be sucked up by DNA, then we're in a sort of totally different category. And there isn't clear evidence about it. Obviously, if there were any strong evidence, they would not have approved the drug. But I will say that the original company that developed molnupiravir abandoned the drug because of concern about mutation, or what's called mutagenicity. And then it got sort of picked up, off the salvage market during COVID by some other venture capital company and then they resold it to Merck, and that's where we are today. So somebody made a lot of money, but not the original developer or original patent holder, because they chose not to proceed even after obtaining the patent. So I think
who knew about the remainder market in
exactly. So I think it does kind of worry me a bit. And now the big advantage of molnupiravir, because you might, after hearing all that, say, well, why would they ever do that? It doesn't interact with anything. You can take that drug and be on
so if you have kidney failure or near kidney failure or something like that.
I have to double check about kidney failure, but warfarin, other blood thinners, no problem. Heart medications, statins, no problem. It basically has zero drug interactions. There is not a single drug that I have found that interacts with molnupiravir. Whereas many, 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 many drugs, antidepressants, blood thinners, heart drugs, statins, all interact with Paxlovid.
Well, that's very helpful to understand.
It has
We
the
are
same 5-day window, by the way.
okay. I was going to ask a question about the. I know that there's talk of a reconfigured vaccine in the fall. Have you read anything about that and what the what the advice is now for people who might be considering a fourth vaccine that maybe were not eligible before? You know, a booster, a second booster.
Yeah. Well, I think I'm reading what you're reading, and it looks like there is sort of a dispute going on in the, at the CDC about I think there are like two camps. One camp thinks that who knows what the virus is going to do, and whether having sort of a vaccine 2.0 is going to be a big advantage by the time it's ready in October. So that camp says, no, just people should just get what they can get now, even if it's the original vaccine, which doesn't seem to offer great protection against the current versions of Omicron, at least in terms of hosting the virus and replicating it. It does seem to provide protection against death and hospitalization, but people still seem to be able to host the virus.
We've got lots of anecdotal evidence of that.
Exactly. Then the other camp in the argument, I think, is saying, well, if we could just focus on the BA4 or BA5 sort of 2.0 vaccine that provides protection against the current Omicron variants, that would be a big improvement. And we should kind of focus on that and maybe even discourage people from getting a booster if they're eligible at this point, because we would be within the 4-month window now if the new vaccine is going to be available in October. And I don't know, I don't know if I don't think there's a way to choose really, who's right. But, I would say if people are kind of have had, well, it depends on what they started with, but most patients have chosen RNA vaccine, and so they had Pfizer or Moderna, 2 original doses, and then at least 1 booster. I think if you're at that point, it's reasonable to wait until the fall, depending on what we hear. I mean, if for some reason there's a hiccup and they say, oh, well, we're not going to have any of that new vaccine ready until 2023, well, that might change my opinion about that. But if it's really going to be available in October, then that seems like the next best option for most people. If you've had 2 primary vaccinations and 2 boosters, that's all that's been recommended so far, and you're not really eligible for others unless you're immunosuppressed. And then there are special recommendations, although probably those patients should be getting Evusheld from their provider who is managing their either the disease that causes the immune suppression, or oftentimes it's substances that are being prescribed and administered that cause the immune suppression. So Evusheld is a preformed antibody and has to be administered every 6 months intravenously.
Okay.
But that would be only for that subset that I talked about.
Right. I know Bainbridge Prepares is doing clinics right now for our youngest community members, 6 months to 5 years. Is that right?
Right.
And I'm guessing that that getting that population inoculated is good for all of us, because it's another way that we sort of slow down the transmission of the virus around our community.
Yeah, I think so. It's a little hard to know how much impact it's going to have. For one thing, because the vaccine that we're using may not stop them from replicating Omicron. And it's a little bit hard to know what the sort of starting point is amongst that population in terms of preformed immunity. children tend to, they have great immune systems and tend to form very, very robust immunity, both to vaccines and to the illness itself. So, I do wonder how many of those kids might have already had COVID and may already have some immunity. I don't see any harm in giving them a course of vaccine, and some of them are quite young and may have been very sheltered. If they're not in childcare, some of those parents have really chosen to kind of shelter those kids, and I think it is important from a development and a socialization point of view that those parents feel that it's sort of ethically okay for them to kind of turn those kids loose and let them socialize with other kids. So that, if nothing else, that's a very, very important aspect of vaccinating that group. All of that said, I'd say there's relatively low uptake as far as we can tell, although there aren't exact numbers about how many eligible kids there are in that age group, but I think we kind of did some back of the napkin calculations, and I think we came up with, well, yeah, it's tricky because obviously not everyone who comes to the clinic is from the island, and estimating, for all of Kitsap is quite complicated. But on the island, there are probably maybe 400 kids in that age group, and I think we're vaccinating about 145, but roughly 150.
Are you open to questions from people here?
Sure.
If anybody has a question that didn't get answered, pop open your microphone.
While people are thinking of their question, one thing that I was trying to look up that is kind of a maybe not as big a problem on Bainbridge, but if you think about it, well, it's a problem on Bainbridge too. If you don't have an existing relationship with a primary care provider, and especially if you don't have insurance, getting antiviral treatment during the 5-day period could be quite tricky. And I spent some time before the meeting because I thought that I saw that there was like a number you could call in Washington if you're uninsured and think you have COVID and wanted to kind of do a phone visit, although you need to know a lot. You need to really know all of your medications, and I don't know how you know your renal function. That seems quite tricky. But I came across it a few days ago at work, but I'm not at work today, and I couldn't find the number. So if there is a route to that kind of sort of televisit that's free, it's somewhat hidden. It was not super easy to find, and certainly on Bainbridge, not so much because of lack of insurance, but in part because of the departure of Swedish. There are a lot of people who don't have a primary care provider.
Yeah, I got a call this morning asking for help trying to find a doctor. Somebody called and said they were here and wanted a doctor and were having a hard time getting one on Bainbridge. So
that might be a separate
that's a separate conversation
separate
here.
Zoom meeting. But it's relevant in terms of just that 5-day window and feeling you want to get started.
If you're vaccinated and boosted and still get COVID, what's the danger of getting COVID twice?
Well, if I understand the question from Terry, the question is, how risky is getting COVID after you've been vaccinated and boosted, or vaccinated, boosted, and maybe had COVID before, and then you get it again. And it does seem that the risk is obviously lower from kind of a statistical standpoint in terms of, as we said at the beginning, hospitalizations and deaths from COVID itself don't appear to be anywhere near the levels of prior peaks. Keep in mind that the hospitalization numbers are somewhat skewed because I don't think the hospitalization numbers distinguish between those who are hospitalized for COVID and those who are hospitalized and found to have COVID. So that makes the hospitalization data kind of a little bit hard to interpret, because hospitalizations are definitely up, but that includes all these people who are hospitalized because they had a gallbladder attack and turned out to have COVID too. But I think the meat of the question is still that, unfortunately, we still don't have a great way of predicting who's at highest risk. And COVID produces all kinds of effects in people, I would say, especially on the clotting system. Maybe even in people who have relatively mild cases, and they may be completely unaware of those effects. And in most cases, it passes and it doesn't cause any harm. But in a small group of patients, those changes in their blood clotting, usually, I think, from people who are more prone to forming clots than people who are more prone to bleeding. But in either case, obviously, bleeding and clotting can lead to problems. And this is somewhat anecdotal, but I do think that I'm seeing, continuing to see an increase in problems related to blood clotting, even with relatively mild cases of COVID. And some of those, I think, do result in deaths. So that would be things like pulmonary emboli and maybe myocardial infarction or heart attack.
And I think the other thing that we've experienced is that getting COVID is not necessarily, it's not a guarantee that you won't come in contact with it or get it again.
Right.
So,
yes. Right. And it looks like, unfortunately, even having had the BA4 illness may not protect you from BA5 subvariant of Omicron, which appears to be the predominant variant at the moment.
Ted had a question. If you're on a course of Paxlovid, should you start to test each day after completion of the 5-day course?
I think that would be desirable. I'm sure that I know that's what they did with President Biden. And if you're willing to sort of engage in the science experiment and have the free tests, which you can still get at, I believe, Say Yes COVID test.
Well, you can get them at the Senior Community Center.
Okay, you can get them at the Senior Community Center, but if you don't want to go out, you can get them at Say Yes COVID test.org once a month, and they come, Amazon delivers them to your door, and that's free. But if you're willing to engage in the science experiment, I would say yes, doing that test for maybe 3, 4, 5 days after you finish the antiviral drug, whichever one it is, really, would be interesting and maybe important in terms of interrupting the transmission of the virus.
And what I read on the CDC site was that it was recommended that if you have COVID and stop having symptoms and you test negative after 5 days, you can, with a mask, rejoin activities, probably wearing a mask for another 5 days or so. Obviously, you're doing the best for the community the longest you can sort of refrain from engaging with other people, but it is with us. So There is an article, Terry says, in today's Seattle Times regarding the telehealth appointment that you talked about, Dr. Cowan, and there's a number 800-525-0127. So
Thank you.
Thank you, Terry.
Thank you. Yeah, I'm going to write it down because I want to make sure that, that our nurses, for example, have that, because it really was not easy to find.
I thought of a question. I wondered, last time we talked, you said that you were treating some people with so-called long COVID. I wonder, but you didn't really know much about it. Do we know more about it than we did a couple months ago?
Well, I think we know. I did see a Times article in the last couple of days that said that something like 1.5% of the U.S. workforce is not at work due to long COVID. So that is, to me, quite startling. That is hundreds of thousands of people, 1.5% of the workforce. So, and that may be an undercount, because of course the criteria for long COVID are not established yet. And that's making, I think, study, treatment, and of course, eligibility for disability, or accommodations from employers. That's all quite tricky when there's not criteria for the disorder. So yeah, it's kind of a mess, I would say. I think hopefully in most cases, at least the cases that I've seen, patients did eventually kind of recover, mostly. But obviously the worst cases, the ones that kind of make it into the New York Times articles, it seems like very, very persistent, disabling fatigue, brain fog. Yeah, really kind of discouraging. I mean, again, I think the silver lining will be that there'll be a lot of research, and we will learn a lot more about this that could help people with other disorders. I think that was kind of some of the context last time, is that for people with like chronic fatigue syndrome, which is kind of an orphan disease at this point, really not a ton of research going into that. I think this could really be super helpful. But it also may turn out to be multiple different problems. COVID is amazingly, has an amazing ability to affect so many different organ systems in so many different ways that long COVID may turn out to be multiple different, subtypes.
Right, and it may be like you were saying earlier about, I can't remember what it was, a treatment for a gallbladder or something, that you come into the hospital, you discover you have COVID, and then these other things that are now.
Well, I didn't mean to imply that there was necessarily a causal relationship. I was just commenting about, that we're learning of a lot of COVID cases in the hospital because the patients everyone gets tested on admission. In some cases, I think there could be a causal relationship. Gallbladder, I suspect probably not. If I had to pick one thing that wasn't caused by COVID, that might be it. But who knows, it really affects so many different pathways. And I think that's still a reason to, to try not to get it. Because it's just, there's just so much we don't know. But fortunately, most patients at this point who do get it seem to pass through it with, the consensus view from my patients is this is like a moderate flu for a few days, and then they start feeling better.
Okay, well, thank you very much for the time. Are you willing to make any comments about monkeypox before we go?
I didn't really. I
know I didn't ask you to prepare for that.
Yeah,
so
I didn't prepare for monkeypox. I probably don't know more than you do.
Okay.
About monkeypox.
Well, Anyway,
I think that, that what I'm reading about the vaccine availability, that seems to me to be the kind of the way out of monkeypox, is ramping up the vaccine availability. There really isn't much vaccine available yet. And once that, they're saying that starting in 2023, there's going to be millions of doses. And as far as I know, it's an effective vaccine. So that seems like the way out of monkeypox.
I won't pin you down on that one. Okay. Thank you so much for making yourself available to us. We really, really appreciate it.
Yeah, it's been, well, I don't know if fun is the right word, but it is very interesting from a scientific standpoint, and yeah, and I think it's important for people to kind of understand the limitations of the medications that we're using, but they're all together a big step forward. And I didn't even talk about inpatient treatment for COVID, which I don't know much about, but I think they're still using, remdesivir and other intravenous drugs for the inpatient COVID patients.
Thank you very much, and thank you for your work with Bainbridge Prepares too.
Yes.
We appreciate you being an active community volunteer.